Assalamu alaikum. Bismillah, alhamdulillah, wassalatu wassalamu ala rasulillah. My name is Abdullah Kaki. I'm a professor of anesthesia and pain medicine, and I'm a member of the National CPR Committee in Saudi Arabia. It's an honor here to be with you today. And my talk will be safety during performing cardiopulmonary resuscitation on a COVID-19 patient. So good evening, ladies and gentlemen in Saudi and the East Mediterranean region. And good afternoon and good morning for the rest of the world. We'll keep the question to the end. And if you have any question, just write it and I will overcome that at the end of my lecture. I hope that you can hear me well. Okay, now this is my center in Jeddah, and this is a member of my department. And for those who don't know where is Jeddah, Jeddah it's on the west part of Saudi Arabia, here on the Red Sea, and this is a photo of Jeddah. So you are more welcome to visit us at any time. I have nothing to disclose. So let's start with the World Health Organization. The World Health Organization declared COVID-19 as a pandemic in last March 2020. And they contributed that to a severe acute respiratory syndrome, coronavirus 2, which is highly contagious and spread throughout the world. And we're all familiar with that. And it's been documented that it's transmitted through droplets, either direct or indirect. And we are in the medical field doing a lot of aerosol generating procedure. And unfortunately, the cardiopulmonary resuscitation is one of this aerosol generating procedure. So we have to be careful when we are doing our CPR. Now, till today, there's more than 58 cases infected with coronavirus 2. 58 million. And the death is around 1,300,000. If we know that 12 to 19% of those required hospital admission, and 3 to 6% of them, they need critical care, and they might end with cardiac arrest and cardiopulmonary resuscitation. So that's a good percentage. So we're gonna face it, whether sooner or later, we will face a case of suspected or confirmed COVID-19 who need cardiopulmonary resuscitation. Now, let's learn from our management in the last few months. In Italy, in Lombardy region, they found that the number of outside the hospital cardiac arrests increased by 58% in comparison to the same time in 2019. And from those, 77% were either suspected or confirmed COVID-19. In the same continent in Europe, in Paris, they found also the incidence of outside hospital cardiac arrest doubled in parallel to the increase of the hospital admission as well. Most of this cardiac arrest occurred at home. So that was the result of the lockdown situation in the whole world. But unfortunately, the rate of bystander cardiopulmonary resuscitation and public access to defibrillation get down, and the overall survival decrease as well, although the number of arrests increased. In the source of the infection in China, Wuhan, they conducted a study on 136 patients with severe COVID-19 pneumonia. And they found that in-hospital cardiac arrest occurred in almost 88% of those patients. And the cause was respiratory in these 88 cases, 88%. Initial cardiac arrest rhythm was asystole in most of the cases, in 90%, and pulseless electrical activity in the remaining 4.4, while only 5.6 or almost 6%, they have ventricular fibrillation or pulseless retard. So the need for defibrillation is not that high because most of the cases is of respiratory cause. This doesn't mean that cardiovascular manifestation is not part of the COVID-19 situation and disease? No. Among those cases, we found elevation of the cardiac biomarker, cardiac enzyme, and troponin. We found more incidence for cardiac arrhythmia, higher incidence for atrial venous thromboembolism, cardiogenic shock, and finally cardiac arrest. Now, most of the cardiac arrest present with a non-shockable rhythm, as I said before, and it's mainly due to hypoxemia. But of course, dehydration, hypotension, sepsis, coagulation abnormality, and pulmonary embolism is another cause for this cardiac arrest. Now, among the 136 cardiac arrests, 4% survived for 30 days. 4 patients, survived for 30 days, which is only 2.9%. And unfortunately, only 1 patient had a good neurological outcome from those 4 patients. For this reason, the International Liaison Committee for Resuscitation tried to conduct a systematic review to find whether COVID-19 create any risk for a rescuer to be infected with COVID-19 or not. So they checked for aerosol generation and infection transmission associated with chest compression, associated with defibrillation, and associated with cardiopulmonary resuscitation in general. They look at the literature, they found 11 studies. Unfortunately, none of them is a good study because 5 are case reports and 3 observational study, and of course, according to the evidence base, 3 observational study is not on the top. And there was 3 randomized controlled study, which is great, but it was on mannequins, not on humans. None of these 11 case studies involved COVID-19 patients. So what was the result of this systematic review? They found that indirect evidence that cardiopulmonary resuscitation associated with aerosol generation transmission, but there's no direct evidence. That they found that defibrillation evidence was so weak. So the evidence in general was not that strong to separate the individual risk associated with specific resuscitation intervention. So the result is totally not significant. So we have to answer this question. Do we need to resuscitate or not to resuscitate? Now, let's take the empty half of the glass and look to the dark picture here. We know that successful resuscitation typically require what? Transfer to the critical care area and require mechanical ventilation. And in many countries, there was no enough ICU bed and no enough mechanical ventilation. From those arrested inside the hospital, only 25% survived the hospital discharge. And as a result of the COVID-19, most of the time a less experienced team was looking after the code because the most expert people were busy in the critical care region or in the emergency room. There was a delay in the initiation of cardiopulmonary resuscitation because of the donning of personal protective equipment. So that might affect the outcome of the cardiac arrest. The resuscitation of the COVID-19 patient resulted in what? In the best case scenario, resulted in a case with COVID-19 with the risk of active clinical deterioration. The risk related to aerosol generation procedure is high, especially with airway management, whether mask and bag ventilation, whether intubation of the trachea, suction of the airway, or even simple chest compression. And on the other hand, COVID-19 infection among healthcare workers means that the number of those people looking after the patient will decrease. So we are losing, not gaining. And in most of the country, there was a significant limitation in the supply of the equipment needed for looking after those patients, whether personal equipment or the alcohol gel or the face mask. So all this discourage us from resuscitation. But at the same time, the human life is so precious. And if somebody arrested in front of you outside the hospital, I don't think you'll actually be able to tell whether he's a COVID positive or suspected or not. So there is a high risk that you leave somebody who needs resuscitation because you're afraid you might get COVID-19 infection. So for human reason, we have to do the resuscitation. And for other cultural, religious part, we have to do the resuscitation. So the full half of the glass forces us to look after those patients. But the challenge here is to maintain the balance between your safety and the patient need. You don't want to expose yourself to infection. At the same time, you don't want to ignore the patient. So this balance is your job as a rescuer in the cardiopulmonary resuscitation. Okay. So what is the risk associated with cardiopulmonary resuscitation in a COVID patient? Now, before we go on that, let's talk about the mechanism of transmission of SARS coronavirus number 2. Now, the main mechanism of COVID-19 transmission is respiratory secretion, although other secretion also carry the risk of infection. This either directly from the patient by airborne or droplet contaminated the surrounding surfaces. And unfortunately, this virus has a good survival for more than 3 days. And this respiratory secretion, it's either a small droplet called airborne particle less than 5 micron, or a large one. When we say large, it's only 5 to 10 micron. You cannot see it. You need an electronic microscope to see it. We call it droplet. So droplets usually fall on the surrounding surfaces and it stay there for 1 or 2 days, and it can spread up to 2 meters, while the airborne particle will be suspended in the air to be inhaled by the rescuer or the surrounding people. Now, so is delivery of chest compression or defibrillation induce aerosol generation? We mentioned the LCOR systematic review, and it was totally inconclusive. But chest compression, it has a risk of generating aerosol droplets. Why? Because it looks like a chest physiotherapy. And from our study, we found that chest physiotherapy technique associated with aerosol generation. So there is a risk of aerosol generation just simply with chest compression. And remember that when you do your chest compression, you are close to the patient airway. So the risk is there. So the best way is to protect yourself, to wear protective personal equipment and a face mask. Defibrillation, on the other hand, is not a high risk, and it's usually lasts for brief time. So the risk from defibrillation is minimum, particularly that you are not going to stay next to the patient when you are doing defibrillation. You will be staying away. You remember, all clear, you are clear. So this gives you some protection. Now, so the LCOR recommendation for cardiopulmonary resuscitation in patients with COVID was summarized in this table. And I will leave it for you for 1 or 2 minutes just to go over it. So if you are doing that, there's a potential to generate aerosol things. It's not a strong recommendation, it's a weak recommendation with very low certainty of evidence. If you are a lay risker, then only chest compression, no mouth-to-mouth breathing, only chest compression. If you are willing to perform mouth breathing and you are good in that, then you have to weigh the risk benefit here. And we will come to that point in the next few slides. If you are a healthcare professional, then you have to use a PPE for all this aerosol generating procedure. And it's also a weak recommendation with very low certainty evidence. And if you are performing defibrillation, then donning is a must also, but you have to weigh the risk of benefit. If that donning of PPE will delay defibrillation in somebody in vertical fibrillation, then no, go ahead with the minimum protection. For those who are unfamiliar, I'm sure that all of you are familiar with personal protective equipment and you're familiar with donning and doffing. If not, then it is time for you to familiarize yourself with that. For minimum droplet precaution, PPE means gloves, short-sleeved apron, fluid-resistant surgical mask, eye and face protection, either by face shield, visor, or any polycarbonated safety glasses or equivalent. If it's an airborne droplet, precaution will be more. You're going to wear gloves, long-sleeved gown, filter face piece, FFP3. If you don't have it, like in our country, most of us, we have the N95. That means that it protects 95% of the time, while the FFP3 protect 99%. You should wear an eye and face protection as well. And if you have the facility of a PAPA, then go for that. A powered air purifying respirator will be the best. That's good. Covered your face would be great with a respirator to ensure there's no risk of breathing the bugs. Now, what about basic life support for adults with suspected or confirmed COVID-19? If the person is a lay person, then, and he wants to resuscitate, then he needs to check that this patient really arrested. He's unresponsive. And here we say we don't come near to the patient. So this look, listen, and feel is not allowed. Or only look. Don't bring your head next to the airway. Okay, so you just look, check the patient, shout, be sure that he's not breathing, then ask for help. Activate the emergency medical services, because this patient is unresponsive, not breathing. If you are alone, you could use your phone, put it on a speaker, and communicate with them, and start a resuscitation. And it's better to place a face mask on his airway. If you don't have a face mask to cover the oral and the nasal orifices, then a cloth or towel covering the person's mouth and nose will be great. And continue chest compression, no breathing. Then if that emergency medical service answered you, then follow the instruction of that EMS person. After you finish resuscitation and the EMS took over, you have to call the authority and inform them. You have to wash your hand with water and soap for 60 seconds with alcohol gel, and get rid of all your clothes as soon as possible, and contact them to find out whether you need isolation or not. Now, if you are an paramedics or emergency medical dispatch staff and you are untrained risk care, then it is your time to be trained and you have a priority here, okay? But if you aren't trained, then just do chest compression only, no airway management. If there's a second man with you helping you, then it's a good time to use the AED, automated external defibrillator. And remember that donning of airborne precaution, the PPE, personal protective equipment, is great, things to protect you. So if you know how to do that, go ahead without delaying resuscitation. Okay, and your employer should provide you with enough PPE equipment. If you are a healthcare personnel, whether inside the hospital or outside the hospital, and you come across a cardiac arrest, then your priority is to look for sign of life. No sign of life, then activate the code if you are in the hospital and ask for AED, okay? Perform the chest compression and ventilation with black mask, And if you don't have a bag mask, then a non-breathing face mask covered with a surgical mask will be ideal things to maintain the oxygenation until you get a bag mask with advanced airway management. If you are less skillful with bag mask ventilation, then chest compression alone, and place the oxygen non-rebreathing mask on the face of the patient. If you are a skillful person, then use both hands to seal the mask on the face, tight without any leakage, and ask the second rescuer to do the chest compression. And each time you give him ventilation, he will stop the chest compression. Otherwise, you will encourage the spread of the virus. It's recommended to use a high efficiency particulate air HEPA filter. If not, then we use a heat moisture exchange filter to limit the spread of the virus from the patient to the environment. This is the algorithm, and it's available on the net, so you don't bother yourself. The only things added here is donning for personal protective equipment and limit the personnel. Always limit the personnel dealing with the resuscitation. There's no need for 10 people to be surrounding the patient, whether outside the hospital or inside the hospital. We need to limit them to reduce the risk of infection. What about advanced life support for adults with suspected confirmed COVID-19? So that was the basic. Chest compression mainly for unskillful layperson. You could do chest compression with ventilation if you are good in that until help arrive. If the arrest is inside the hospital, then you identify as early as possible. That's really arrested patient. And ahead of that, if the patient in a high dependency unit or in a critical care region, and there's a high chance that this patient is going to be arrested in the next 5 minutes or 10 minutes, then here it's your job to manage him and prevent the cardiac arrest, what we call a rapid response team. If his saturation is 60 and 50, and you know that he's going down the tube, then arrange for elective endotracheal intubation. Don't wait until he's arrested and you are under a lot of stress to look after him or donning. No, you have time to donning your PPE and go and manage the patient. So this is an important thing for in-hospital cardiac arrest. If you ended with a cardiac arrest, unfortunate, then here another issue should be raised. And this is a dilemma, that whether to do resuscitation for the patient or not. Now let's assume that this patient is a severe COVID-19 respiratory failure, who is above 75, with a multi-organ failure, and if you resuscitate, the survival rate is not that great. Then here the decision, shall we go for do not activate cardiopulmonary resuscitation or not? We cannot create a general rule that you apply on all patients. No, you have to individualize each case and take a decision on each case. Okay? If the patient is responsive, not breathing, shout for help, activate the code, call for 222, and then start your resuscitation. For the in-hospital cardiac arrest, we apply the defibrillator bags and deliver shock from an AED or a defibrillator if the shockable rhythm was noticed. But most of the time, we say it's hypoxia-related cardiac arrest, so most of the time we don't need defibrillation. Again, restrict the number of staff in the room, and if it's done in a negative pressure room, it will be great. If you don't have that, then just restrict. Get a gatekeepers to prevent people from getting in unnecessarily. Only those expert in airway management and resuscitation should be there to manage the patient as fast as possible. Place an oxygen mask and give oxygen. As I said, if you don't have a bag mask, then a non-rebreathing oxygen mask will provide a good passive oxygenation, and you cover it with a surgical face mask. You have a bag mask device, then do that and apply compression ventilation 30 to 2 as usual. If there's two persons, remember to pause each time the person giving ventilation, no chest compression, okay? Use a HEPA filter or HMA filter, whatever you have, to reduce the risk of contamination. And if you have the capability to use a video laryngoscope to intubate, that would be great, because you will keep yourself away from the airway instead of using a direct laryngoscope. That one thing. If it's difficult to intubate the trachea, then go for supraglottic airway with a laryngeal mask or pharyngeal airway or esophageal tube. Now, if the resuscitation continue for 10-15 minutes, you could use an external chest compression, a mechanical chest compression. That, of course, depends on the weight and height of the patient, but this will save the rescuer and keep him away from the patient and maintain a good cardiac output. And you have to be familiar with this mechanical chest compression, of course, device before the time of arrest. At the end of resuscitation, you have to remove your contaminated gown, gloves, and the rest, doffing in a completely self-contaminated area away from others. And then you do your team debriefing to prepare for the next cardiac arrest. The same things here. For ACLS, you will find it on the net. So again, don PPE, limit the person, and continue with the rest. It's all the same like the ACLS. I'm not going to cover that just for the sake of time. Now, if the patient is intubated and he arrested, then you need to wear PPE as well. The presence of a tube inside the trachea doesn't mean that it's safe to resuscitate him without PPE. You have to wear your PPE. And we always tend to take the patient off the ventilator and use an ambu bag. No, keep him on the ventilator, increase your FiO2 to 100%, and put him on, depend on his oxygenation and his pulmonary situation, either volume control or pressure control. Increase the pressure limit because you might need that higher, 35 or 40. Turn the trigger mechanism on the ventilator off. Otherwise, each time you do chest compression, the machine will give a breath. And then before you do all this, be sure that this arrest is not due to ventilator failure or tube disconnection. If for any reason you need to disconnect the ventilator, then clamp the tube to minimize the spread of the bugs. And use HEPA filter again between the ventilator and the patient. Now let's go over this case just to stimulate you. He's a 76 years old male patient admitted 5 days to the ICU with complication of COVID-19, ARDS, and pneumonia. They managed him in prone to improve his oxygenation. Unfortunately, he arrested and they called you as a team member of the Code Blue. So, are you going to transfer this patient to supine position or not? Answer yourself, write it. I'm not interested in the answer, and it's not an exam. And are you planning to discontinue the patient from the mechanical ventilator or not? This is a common situation now with the COVID-19 patient in the critical care area. Now, if the patient is in prone position, and you could resuscitate him in prone position, which is so difficult to turn him to supine, then go ahead and resuscitate him in prone position. Now, question number one, if this patient is not, of course, intubated, then it's so easy to turn him to supine. But remember that you have to don your PPE and turn the patient immediately to supine because he is not intubated, and start your chest compression and then your airway management. But if the patient is intubated, like our patient, and he's prone, then chest compression by turning him means that you disconnect him from mechanical ventilation. So in that situation, there's a risk you're gonna spread the virus. So what you're gonna do, you will do compression, chest compression in prone position. And usually we go between the two scapulae, between T7 and T10, and we start our compression on the back at a rate of 2 compression per second and a depth 5 to 6 centimeter. You could continue that as long that his blood pressure is reasonable. The diastolic blood pressure is not less than 25 millimeter mercury. Most of the patients in the ICU, they have an arterial line, so that's easy to figure. And there's no other reason to turn him to supine. Like what? Like accidental extubation. If unfortunately during the resuscitation, the patient is accidentally extubated, then you have to turn him to supine. Or you are unable to restore his circulation rapidly, he is in prone after 20 minutes, then you have to turn him, maybe after 15, depend on the patient. What about defibrillation? Are we able to do defibrillation prone? Yes, it's so easy. You place your pads either on anterior and posterior, that's one approach, or in the two axilla, the arm belt. If you are using a defibrillator pads, then the arm belt will be a good choice. If you are using an EED, then you put one pads anteriorly and one posteriorly, and you defibrillate if the patient has ventricular fibrillation or partial ventricular tachycardia. Case number 2. Now, you are at home, your cousin is 5 years old. Suddenly he stopped breathing, turned blue, and you are the expert in CPR, or the family member looked at you. Are you going to give him a mouth-to-mouth breath, knowing that most of the cardiac arrest among pediatric group is respiratory? Or are you going to perform chest compression alone? Again, try to answer the question and see whether you are doing good or not. Now, if the child is susceptible to be COVID-19 or confirmed, we know that most of the situation, they are with mild symptoms. COVID-19 gives a severe picture among children if this child has a comorbidity or he is immunocompromised for one reason or another. And most of the cardiac arrest among children occur at home, as we mentioned before. So most of the time the rescuer is a family member like you. You're a cousin. So what to do? I think if this child is infected with COVID, you are living with him in the same environment, so you will be either a carrier or infected already. There is no harm of giving him a rescue breath. Can you use a barrier? Yeah, you could use that to reduce the risk. Now, if this happened outside, then again check for responsiveness. Don't bring your head next to the mouth and nose. Only shout, shake, and look for chest rise. No breathing, this means that he's arrested. You call for MS and then start compression. If there's 2 rescuers, then one will call the EMS. If not, compression only CPR. The different things among children from adults that you don't cover the mouth and nose. Why? Simply because this piece of cloth might obstruct the airway. On the other hand, leave it open because you're going to get passive movement of the oxygenation. So that's another good way to ensure maintaining of his oxygenation. Now, AED only used if the patient has a cardiac history or he's older than 1 year, or you are witnessed a sudden collapse like this patient, then it might be of a cardiac, or then AED is indicated. This is the algorithm, and again, don't PPE, limit the personnel. We try to make the personnel 4 or less as much as possible. If it's inside the hospital or outside, it's only 2 would be more than enough. And this is the same whether you are a single rescuer or you are 2 when you call the AMS before you do chest compression or after that. The common question that you got in your BLS and PR and PALS. Now, what about the advanced life support for pediatric COVID? In the pre-hospital or inside the hospital, again, PPE should be worn by the health staff. Small number in the room or small number resuscitating the patient, PPE should be worn. Do not delay CPR to secure an invasive airway. Forget about the airway. Chest compression, you're not expert, chest compression is enough. And there's no strong evidence that extracorporeal life support, extracorporeal oxygen membrane is of help for children. So shall we use it or not? There's no strong evidence. It depends on the situation and the case. And this is again for ACLS among children, the same, and you could find it easily on the net. Now, what about neonatal life support? Now, the transmission of COVID-19 coronavirus 2 from the mother to the fetus is unlikely. There's no strong evidence that it's being transmitted from a mother to a fetus. Though there was one case, but it's not strong evidence. Now, we found that maternal infection with COVID induce premature labor, but it doesn't induce spontaneous preterm labor. Okay? So the standard approach is the same like any other COVID-19 patient. If the mother is not clinically suspected, we have to treat the patient the same way we treated non-infected patient according to the rule and regulation in your center. If it's suspected or confirmed, then full airborne precaution, PPE, isolation of the mother should be taken. If the mother could be isolated in a negative pressure room, that would be great. And the resuscitation of the baby should take place at least 2 meters away from the mother because she's confirmed or suspected. Mask should be worn by the mother. Alcohol gel should be given to her. If you don't have this possibility of 2 meter distance, then use a partition or locate your resuscitation area separate from the delivery area. And be careful that the OR is a good environment for droplet and airborne spread. So we have to be over cautious with the mother and the management. If the mother ended with cesarean section, remember that diathermy is another way to transmit the virus. Not always airborne, so remember this. So you should wear your PPE, your N95 or FFP3 to protect your lung. For the pre-delivery assessment of the mother should be done by phone interview. If you are the only one to look up the patient, then no need to go to the room. You could ask the mother to answer the phone and consult her about the whole problem. Now, if you are from the neonatal team attending the delivery of this suspected or confirmed positive mother, then again, you have to check for resuscitation area. You have to wear your PPE and minimize the number of people in the room. And after delivery, you have to change to the immediate management of the baby following the delivery. In the presence of suspected or confirmed, delay cold clamping. So you have to give the baby the benefit. We should only pass to the neonatal team if intervention is needed. If the baby is crying, he's fine, he doesn't need resuscitation, no need to give him the neonatal team. Keep him with the mother, keeping in mind that this mother is wearing her face mask and gloves. The wet towel that you dry the baby with it's a contaminated towel and should be treated in a proper way. HEPA filter should be used if you are using a T-piece or a face mask to resuscitate the fetus. two-person airway is better than one to maintain a good seal and reduce the leakage. And again, minimize this erosive generating procedure to the minimum. If the patient is crying aggressively, no need to intubate him, even if there's meconium, because he is crying aggressively. And try to find the most experienced person to look after the child. Okay? After resuscitation, you separate this COVID-positive mother from her baby according to the local guideline. And then if you need to transfer the baby to the ICU, or neonatal ICU, then again you transfer the baby in a closed incubator and minimize the exposure of the incubator to the surrounding. Keep your PPE all the time on, and then get rid of it in an area assigned for doffing. What about teaching CPR and training during the COVID-19 era? Now, teaching program includes a specific intervention. So we have to change the whole teaching criteria to go with the COVID-19 pandemic. So PPE must be part of the CPR education. If the center is unfamiliar with donning and doffing, then CPR teaching is the best way to teach them how to put on the personal protective equipment and how to take it out. You need to modify the site for teaching, and you have to maintain the social distance between the candidate and limit the number of the candidate to 4 to 6. Okay? And they all wear a surgical mask. All should be checked for symptom of COVID-19 before entering. Anybody with symptom of COVID-19 or high temperature, he shouldn't attend any training courses. Washing the hand with alcohol gel is a must, and maintaining the social distance is another great thing. No mouth-to-mouth ventilation during the teaching of BLS or ACLS. All the equipment, including the mannequin, should be cleaned with alcohol solution after each scenario, not at the end of the day. So after each scenario, it should be cleaned using disinfectant compatible with the material. So you don't want to damage your material. And as I said, rearrange the course program to avoid simultaneous breaks for different groups. So you avoid any intermingling. Don't let the people crowd in one area. We are in the Saudi Heart Association encourage the self-directed learning and online courses. So distance learning, self-directed learning, virtual learning is another good way to teach people about CPR during the pandemic. Those coming for recertification, there's no point to ask them to come. Just extend their certificate for a year to reduce the stress of involving many candidates and many instructors. And if you have to do that, then keep the number to less than 6 candidates per group for hand-on training, no mouth-to-mouth training, as I say. The candidate and the instructor should have a PPE worn throughout the course, and enough PPE should be available for the training. Those who are close to patient with COVID-19 and those with the risk to treat person with COVID-19, they have a priority to be taught how to do CPR. So somebody in the dermatology clinic is not a priority. Somebody practicing in the ER, you need to do CPR training first. Now we come to the ethics part. Now, we know that the demand on the ICU bed, on mechanical ventilation, on medication, on test material, on PPE is increased significantly with the pandemic. There's insufficient resource and there's limited capability, limited number of healthcare staff, and exaggerated fear among those staff as well. So all this affected our decision. The general principle of ethics and resuscitation remain valid. Each person needs and he deserves a resuscitation. But as I said before, if the patient is terminally ill with cancer, with METs, multiple organ failure, then there's no point to resuscitate. So you have to implement the criteria for withhold and withdraw resuscitation according to the legal, cultural, and religious rule and regulation in your country. Careful assessment for each patient need to be done. There's no general rule that you could apply to all patients. And remember that the blanket criteria or the categorical criteria is not acceptable. You cannot come and say all patients above 75, no resuscitation. That's totally unacceptable. Somebody above 75 and he's stronger than 25 years old, he deserves that. Somebody above 70 or above 50, but he has congestive heart failure, end-stage renal failure, with prostate cancer, and now he's in a COVID. So it's different. So we cannot generalize the rule. This is so important in our decision. Finally, we have to ensure the safety of yourself, of the patient, and of your colleague and bystander. Thank you for your time. And this is my email there in the bottom. If you want to contact me, feel free at any time. Thank you. It's time now for questions. This extra references for anybody interested in reading more, you can go ahead and read. I will leave it there so you can make a copy from there. Any questions? Anas, he said, we are not going to do the field step. You mean the field step for arrested child, Anas? No, you do that. But as I told you, if you are an expert in the airway, then chest compression. Yeah. If you are living with a child and you're exposed to the same environment, then breast to breath is fine. Any other questions? No, look, listen, feel, no. We don't do look, listen, feel. We just look. Look for chest raise, and we shake and shout to see any responsiveness. But listen and feel is not recommended. No. You're welcome, Anas. If the arrest outside the hospital and you are alone, then chest compression. You could, as I told you, if you have a mobile, and all people in the world now, they have a mobile, so call for 911, 122, whatever, and put it on the speaker and start your chest compression. If the patient on ECMO, he won't be arrested because actually the machine is doing the cardiac function. So there's no big problem. If the machine is not doing the work, then there's no point for it. So if you are asking whether this recommendation are integrated in the national guideline, yeah, this recommendation is the recommendation of the Saudi Heart Association, and the Red Crescent are following the Saudi Heart Association recommendation. And by the way, this recommendation is the same for the European Council for Resuscitation, for the ELCOR, and for the American Heart Association. They all recommend chest compression only. Yeah, Sophia. Sumaya, what about CPR and CRRT? What do you mean by CRRT? Continuous renal replacement therapy. No, it's a different story. If somebody in an end stage renal failure, you have to treat him in the same way. This is in hospital cardiac arrest, and PPE should be worn, and you start resuscitating. Chest compression, of course, you stop the continuous renal replacement therapy at that time and start chest compression and manage his airway in the way I told you before. Any other questions? Yeah, for endotracheal intubation, somebody was asking if we need to do that. A negative pressure room is needed. Yes, if you have a negative pressure room, that would be great. But if you don't, then we prefer to intubate him by video laryngoscope. And an expert should do that to limit the time for intubation. So you limit the aerosol generation procedure. But negative pressure room is recommended for all, even for resuscitation, if we have that. Yeah. Unfortunately, most of the hospital, they don't have it. And if they have it, they have 2 or 3 for isolation cases. But HEPA filter is another way to limit the spread of the infection. Tisam asking, is there any certificate for this? I don't think so, but you could contact the organizer. The Patient Safety Center will give you an answer better than me. Any more questions? It seems that it's clear. Okay, we'll give you 3 more minutes. If no more questions, then I'll say goodbye.